she said. I understand that. I'm telling you, the pain is a 9 out of 10, and it started 4 hours ago in the lower right quadrant. I have a fever of 101.4. I'm a medical professional, and what I'm describing to you is consistent with a perforated appendix. He looked at her then, really looked at her, the way a particular kind of looking works, the kind that is less about seeing and more about sorting. He took in the sweatshirt, the hair that had not been managed since the morning, the absence of the markers he was used to reading as authority. He said, I understand you're uncomfortable. Everyone out there is uncomfortable. We'll get to you. You're not hearing me, she said, quietly but with precision. I need imaging. Now, he said, ma'am. The word landed like a door closing. Please, take a seat. She looked at him for a moment. A very still, very contained moment, the kind that only people with extensive training in high-stakes environments can maintain when the body is in significant pain and the mind is watching itself be dismissed. Then she reached into the front pocket of the sweatshirt. She produced a badge. She held it up, badge face out, the way she had held it 10,000 times in the OR, in the on-call room, in the hallways of this very hospital, where she had worked for 11 years. She said, My name is Dr. Nadia Simone Okafor. I am an attending cardiothoracic surgeon at this hospital. I have staff privileges in this building. I am presenting to your emergency department as a patient with symptoms consistent with acute appendicitis, and I am asking you, clearly and on the record, to initiate a workup. The intake nurse at the station beside him had gone very still. The resident, 29 years old, 4 months into his first ER rotation, whose name was Dr. Callum Marsh, stared at the badge, then at her face, then at the badge again. Then all the color left his face. Her name was Dr. Nadia Simone Okafor. She had a medical degree from Johns Hopkins. She had completed her residency at the Cleveland Clinic and her fellowship in cardiothoracic surgery at Columbia Presbyterian. She had been an attending surgeon at this hospital for 11 years. She had performed over 2,000 open-heart surgeries. Last Tuesday, she had repaired the aortic valve of a 63-year-old man who was currently recovering in the cardiac ICU on the 6th floor of this same building, 3 elevators above where she was standing in a gray sweatshirt being told to take a seat. In 18 minutes, she was going to be in a CT scanner. In 22 minutes, the radiologist on call was going to pick up his phone, and by midnight, the chain of events set off in this ER lobby was going to reach the desk of the hospital's chief medical officer in a way that nobody in this building was going to recover from quickly. But before we get there, have you ever had to prove that you were in pain? Have you ever had to argue for your own body in a room full of people whose job it was to listen? Let me take you back. 24 years. The morning Nadia Okafor decided to become a surgeon, she was 11 years old, and her mother was dying. Not immediately, not in the sudden way of some deaths, but in the slow, deliberate way of a body that has been failed by the systems that were supposed to sustain it. Her mother's name was Adana. She was 37 years old. She had been having chest pain for 6 months. She had been to the emergency room twice. Both times she had been given antacids and told it was likely stress. Both times she had been sent home. The third time, she did not go to the emergency room. She went to work because she could not afford another day off, and she collapsed in the break room of the hotel laundry facility where she had worked for 9 years, and a co-worker called 911. And by the time the ambulance arrived, the heart attack that had been building for 6 months had done what untreated heart attacks do. She survived. But the word survived in that sentence is doing complicated work. She survived with a damaged left ventricle and a long recovery and a quality of life that would never fully return to what it had been. And she survived knowing, and Nadia, who was 11 and had been in the waiting room the night of the collapse, also knowing that the 6 months of antacids and the 2 early dismissals and the face on the first error doctor who had looked at a 37-year-old black woman in a hotel laundry uniform describing chest pain and decided what he saw were the chain of events that had produced this outcome. Nadia had sat in the cardiac waiting room for 6 hours the night of her mother's collapse. She was 11 and she was alone. Her aunt was on her way from 2 counties over. Her father was not in the picture, and the hospital had no policy for what to do with a child sitting by herself in a plastic chair reading the same page of a school library book over and over because she could not make her eyes move forward. A nurse had noticed her, a woman named Delphine, who had been in the cardiac unit for 22 years, who had the specific quality of attention that long-tenured cardiac nurses develop, the ability to hold the whole room in peripheral vision while focusing on what's directly in front of you. Delphine had brought Nadia a cup of apple juice and a pack of crackers from the unit's family pantry, and she had sat down in the chair beside her for 8 minutes. 8 minutes that she did not have. And she had said, "Your mama is in the right place now. The right people are working on her. We're not going to let her go." She had not promised the outcome. She had promised the attention. That was the precise and careful thing she said. Nadia had heard the difference. 6 years later, Nadia Okafor applied to Johns Hopkins School of Medicine with an application that included, in the personal statement, a single paragraph about that waiting room and those 8 minutes and the understanding she had arrived at, sitting there with crackers and apple juice and a library book she couldn't read, that the difference between the first 2 ER visits and the night of the collapse was not the severity of the heart attack. The heart attack had been building all along. The difference was attention, who got it and who didn't, and why, and the specific chain of consequences that followed from the distribution of that attention in rooms where attention meant everything. The admissions committee at Johns Hopkins circled that paragraph. They wrote in the margin of their internal notes, which Nadia would not see for 15 more years. When a Johns Hopkins administrator showed it to her at an alumni event, 3 words: she understands the stakes. She had understood the stakes. She had never stopped. She chose cardiothoracic surgery specifically, deliberately, with the kind of intention that does not waver. Not despite the difficulty, it is among the most demanding specialties in medicine, with the longest training pipeline and the highest technical threshold. But in some sense, because of it. Because the heart is where the attention had failed her mother. Because if you were going to repair something, you should repair it at the origin. She was good at the surgery the way certain people are good at things that required them to become someone, not by accumulating a skill, but by integrating it, so that the precision and the judgment and the ability to remain steady when a patient's pressure drops on the table became not things she did, but things she was. Her attending during fellowship had told her, at the end of her 2nd year, that she had better hands than anyone he had trained in 15 years. She had thanked him. She had gone back to the OR. She had come to this hospital 11 years ago, recruited by the chief of cardiothoracic surgery, at the time, a man named Dr. Bernard Ossie, who had trained at Columbia the year before she arrived and who had called her during her job search with a specificity of purpose that she respected. He had said, "I want to build a department that looks like the patients it serves and performs at the highest level. Come help me build it." She had come. In 11 years, she had performed over 2,000 surgeries. She had a complication rate that sat in the bottom 4% of the national benchmark. She had trained 9 residents who were now attendings at programs across the country. She had published 16 papers. She had given grand rounds lectures at 7 institutions. She had, in the quiet side of the work that doesn't appear in CVs, mentored 23 medical students who had rotated through her service, most of them students from backgrounds that looked like her own, students who had needed someone to notice them, the way Delphine had noticed an 11-year-old in a plastic chair. She had also, in 11 years of working at this hospital, presented to its emergency department as a patient twice before tonight. Both previous times she had been seen promptly. Both previous times she had been in scrubs from the OR. Tonight she was in a gray sweatshirt. She had developed symptoms during an evening at home, fever rising, pain sharpening through dinner, the clinical calculus running in parallel with the lived experience of hurting, and she had driven herself in because the pain was escalating in a pattern she recognized and did not want to manage at home any longer. She had left the house quickly. She had not changed out of the sweatshirt. She had brought her badge from habit, the way she always had her badge. It was clipped to the sweatshirt's front pocket, but she had not thought, until Dr. Callum Marsh told her to take a seat for the 3rd time, to hold it up. She had spent 4 minutes being reasonable before she reached for it. 4 minutes of describing symptoms with clinical precision, of being told she would be seen in 2 to 3 hours, of explaining the differential with the same vocabulary she used in morning rounds, of being looked at with the specific expression of someone who has decided that the information being provided to him does not require updating his original assessment. 4 minutes. On a normal night, she might have waited longer because she understood emergency departments, and she understood triage, and she had patience for the process. But the pain was a 9, and the fever was 101.4, and she had been a surgeon for 16 years, and she knew what her body was telling her. She held up the badge. Dr. Callum Marsh stared at it. The intake nurse, whose name was Rosario, and who had worked this desk for 9 years, and who had, in those 9 years, seen Dr. Nadia Okafor pass through this lobby on her way to or from the cardiac unit more times than she could count, said, "Dr. Okafor." Not a question, a recognition. Marsh said again, You work here," she said. 11 years, he said, with the reflex of a man reaching for something that is no longer there. "I didn't. You're not in scrubs. I didn't," she said. "I know." She said it without heat. She said it the way she said difficult things in difficult rooms, plainly, precisely, and with the specific stillness of someone who has decided that losing composure is not available to her right now, because she needed a CT scan and losing composure would slow the process. She said, "Dr. Marsh, I need imaging. Please initiate the workup." He moved. He moved immediately, and he moved fast, with the galvanized quality of a person who has understood, all at once, the full shape of what has just happened, and is trying to compress the remaining time between the mistake and the correction. Rosario was already at the keyboard. In 18 minutes, Nadia was in the CT scanner. In 22 minutes, the radiologist on call, a woman named Dr. Sarah Kamani, who had been in the reading room for 4 hours and who saw the name on the order and frowned and called the ER desk to confirm she was reading it correctly, had the images. What the images showed was exactly what Nadia had described. Acute appendicitis, not yet perforated but approaching that threshold with the clock running in one direction. Dr. Kamani called the ER desk. Then she called the surgical attending on call. Then, because she had been at this hospital for 6 years and she understood what was in front of her, she called the chief medical officer's cell phone directly. The chief medical officer was a man named Dr. Theodore Abrams. He had been in the role for 3 years, and he was not a man who was easily surprised, which made the quality of his silence on that phone call. When Dr. Kamani told him what she was looking at, something that Dr. Kamani would remember clearly for a long time. He said, "She's here right now? As a patient?" Dr. Kamani said, "She's prepped for emergency surgery." He said, "Who's the attending?" Dr. Kamani said, "Dr. Park is on call." He said, "Get me the intake record and the timestamps, all of it." A pause. "And tell Dr. Park I want a direct debrief when she's out of recovery." He was in the hospital within 40 minutes. Not because hospital policy required it, but because Theodore Abrams was the kind of administrator who, when someone on his staff experienced a systems failure in his building, did not manage it from a distance. Nadia came out of surgery at 1:14 in the morning. The appendix had been removed laparoscopically. Dr. Park had done the procedure and had done it well, with the efficient precision of a surgeon who's been woken up and is running on caffeine and training. In the recovery room, when Nadia was clear-headed enough to be coherent, Dr. Abrams was there. He said, "How are you feeling?" she said. "Like someone just took out my appendix?" He said, "Yes." A pause. "I've been reviewing the timeline," she said. "I know." He said, 4 minutes. She said, "Yes." He said, "In your own hospital," she said, "Theodore." She used his first name because they had worked together for 3 years, and she was in a recovery room at 1 in the morning. And formality was unavailable to her. "I know what I'm going to say, and I know what you're going to do, and I want to do both of those things. But right now I need to sleep," he said. "Of course," he stood. Then he said, "Nadia, I'm sorry this happened." She looked at him. "I know you are," she said. "Now do something about it." He did. What Dr. Theodore Abrams did about it was not a press release, and it was not a quiet internal memo, and it was not the administrative equivalent of a closed door and a handshake. It was a process, and the process was thorough, and it took 4 months, which is slower than anyone would have liked. and faster than these things usually move. Dr. Callum Marsh was placed on a performance improvement plan within 72 hours of the incident, with specific remediation requirements around implicit bias training, patient presentation assessment, and clinical listening protocols. The improvement plan was not punitive in the sense of ending his career. He was 4 months into his first rotation. He had made a failure of perception rather than a failure of medicine, and the question of what to do with a young doctor who had demonstrated a bias. That is, in the research, endemic and documented and trainable was not the same question as what to do with malice. But it was documented. It was in his file, and the documentation contained in plain language a description of what had happened, including the 4 minutes, including the 3 requests for imaging that had been declined, including the words "ma'am" used as a door. The hospital's patient experience and equity team conducted a full review of ER intake protocols, which produced, over 4 months, a revised triage assessment framework, a mandatory annual implicit bias training module for all clinical staff that was not the box-checking variety, but a simulation-based program that had been developed with external researchers, a revised patient self-report system that gave more weight to patients' own clinical descriptions of their symptoms, and a formal patient advocate position in the ER, whose specific function was to ensure that patients who were not being heard had a mechanism to be heard. The position did not carry Nadia's name in any official documentation. Inside the hospital, it was called the AFOR protocol, not by administration, by the nurses, the residents, the technicians, the people who understood what it was for. The name moved through the building the way names like that move, informally, accurately, with the specific authority of people who are closest to the thing being described. Nadia returned to the OR 6 weeks after the surgery. She returned at 7 in the morning, which is when she always arrived because she had never been a person who eased back into things. Her first case was a scheduled valve repair, a 58-year-old woman who had been on the surgical list for 3 weeks, and she was in the OR for 4 hours and 40 minutes, and the case went cleanly. And she stood in the scrub sink afterward with the specific quality of stillness that surgeons have after a long case that has gone right, the quiet of the body that has been fully used. She had one more thing to do. Dr. Callum Marsh was on rotation in the cardiac unit that week, part of his expanded clinical exposure under the improvement plan. Nadia found him in the hallway outside the family waiting room, the same family waiting room where, if you followed the geometry of this hospital across 11 years, a plastic chair still sat in approximately the same position as the chair where an 11-year-old girl had once sat with crackers and apple juice and a library book she couldn't read. She said, "Walk with me." He walked with her. He was clearly terrified, which she registered without satisfaction, because terror was not the point. She walked him to the window at the end of the hallway. She said, "Look at that waiting room." He looked. She said, "I sat in a waiting room like that when I was 11 years old. My mother was on the other side of those doors." She had been to 2 emergency rooms in the 6 months before that night and been sent home both times. Antacids. Stress. She's a woman of a certain kind in a certain kind of room, and the people in that room made a decision about what they were looking at before they looked at it. She paused. She's alive. She had a heart attack at 37, and she's 61 now, and she's alive. But she has been living in a compromised body for 24 years because someone didn't listen. Marsh said nothing. She said, "I became a heart surgeon because of what happened in that waiting room. Not because of the medicine, because of the failure. I spent 16 years trying to correct it." She looked at him. "You almost added my name to the list of people who weren't listened to. In my own building, in my own hospital. Do you understand what that means?" he said. "Yes," she said. "I don't think you do yet, but you will. That's the job." She paused. "You're going to see this. You're going to see it happen to patients throughout your career. Some of them will have the vocabulary I have, or the badge. Most of them won't. And the ones who don't are the ones who needed you to listen most." She looked at him directly. "Every time you walk into a room, the question is, are you going to see the person in front of you, or the story you already decided about them?" He said, "I understand." She said, "Good." She turned to go. Then she stopped Dr. Marsh. You're going to be a good doctor. The fact that you know what you did and you've been living with it for 6 weeks tells me that. Don't let it make you timid. Let it make you better. She walked back down the hallway toward the cardiac unit. He stood at the window for a long time. Nadia's mother, Adana, was 61 years old and lived in a house in Decatur where she had moved 20 years ago to be closer to her daughter. She was not fully well. She would not be fully well. The left ventricle had seen to that. But she was present and deliberate, and she tended a garden in the backyard that had, over 20 years, become the kind of garden that other people came to look at. She had not been told the details of the appendix incident immediately. Nadia had managed the recovery quietly, as she managed most things, and Adana had learned the outlines the week after. When Nadia came for Sunday dinner, and Adana noticed the way her daughter was moving and said, "What happened to you?" Nadia told her. Adana listened without interrupting, which was her way. When Nadia finished, Adana was quiet for a moment. Then she said, "Did they listen eventually?" Nadia said, "Eventually." Adana said, 4 minutes, Nadia said. Adana said, "After 60 seconds, they should have known." She set down her fork, but eventually is not nothing. She got up and brought the rest of the food to the table. She served Nadia first, the way she always had, the way she would until she couldn't. They ate together in the way of women who have been through the same fire from different angles and found in each other's company the specific comfort of not needing to explain it. After dinner, Nadia washed the dishes and her mother sat at the kitchen table, and Adana said, "Not for the first time and not for the last." "You became a heart surgeon," Nadia said. "Yes," Adana said. "Because of me," Nadia said. "Because of what happened to you," Adana said. "Same thing." Nadia looked at her mother, 61 years old. Garden-dirty hands folded on the table, the face that had been in her mind on every difficult night in medical school, and every hard case, and every morning she had driven to the hospital in the particular gray of 5:30 a.m., wondering if she had the energy to do it again. She looked at her, and she said, "Yes, same thing." She dried her hands. She hung up the dish towel. She sat back down at the table. They stayed until it was late. If this story reached you, if you felt something when she reached into that front pocket, please like this video, share it with someone who needs to hear it, and subscribe if you're here for the first time. Hit the bell. And tell me this, have you ever had to prove that your pain was real? Have you ever been in a room with someone whose job was to help you and had to fight to be taken seriously? Tell me, because I think you know exactly what I'm talking about. Here's what really gets me. Nadia Okafor was not dismissed because Callum Marsh was cruel. That's the easier story, and it's not the true one. He was not a cruel person. He was a person who walked into a room with a set of unconscious assumptions about what a patient in pain looks like, about whose description of their own symptoms deserves to be acted on immediately. And those assumptions were so deeply built into the architecture of his perception that he did not know he was using them. He thought he was triaging. He was sorting. The research on this is not ambiguous. Black women in American emergency rooms wait longer for pain treatment. They receive less pain medication when they do receive treatment. They are more likely to have their symptoms attributed to anxiety, to stress, to hypochondria. They are less likely to be believed. These are not anecdotes. They are measurements taken across thousands of cases and multiple institutions, and they represent a systemic failure that has been documented and named and published. And that continues, nightly, in emergency rooms across this country to produce outcomes that can be measured in organ damage and years of life. Nadia Okafor had a badge. She held it up. She was seen. Most people don't have the badge, and I want you to think about that, not abstractly, specifically. Think about the person who came after her in that lobby. Think about the person in the seat she would have been assigned if she had complied. Think about who is sitting in waiting rooms right now in this country, describing pain in plain language to people who have already decided what they see, who do not have a badge to hold up, who have only the truth of their own bodies and a system that has been documented, repeatedly and rigorously to underweight that truth when it comes in certain packages. The Okafor protocol is a real thing now, in one hospital, because one woman on one night did not comply, because she reached into her pocket. But here is the question I want to leave you with. Not about the medical system, about you. In your life, not in a hospital. In your life. Where are you the one with the privilege of deciding whether to listen? Where are you the gatekeeper? Where are you the person who gets to determine whether someone else's description of their own experience is credible? And are you looking at the sweatshirt? Or are you listening to what they're saying? Because the difference between those two things, in a hospital and everywhere else, is not administrative. It is not procedural. It is not a protocol or a training module or a revised intake form. It is attention. Who gets it and who doesn't and why? Delphine knew. She sat down for 8 minutes and she gave it.